Okay, perfect. Well, I got to make sure, especially when you're recording now, that y'all can actually read like the letters, right? Like read the letters, right? So first of all, good evening. Thank you for joining. Thank you for joining. Remember to like, share, especially if this is your first time catching this series. What do we do here? I am yours truly, Dr. Barry Pierre. Thank you for another episode of The Real Physician Reacts. This is where we come every Thursday evening. We come special to TikTok. Special to TikTok because I love TikTok. And we just talk about something that hit my social media feed, something that someone sent me, say, hey, Dr. Pierre, can you talk about this? What happened, went down. And this is actually old, like I hate to say old news, right? Because, someone passed away, right? But this is news that someone reached out to me, said, hey, like, I did not realize diabetes was like that. And if this is your first time following me, this is a phrase I like to say all the time when we talk about diabetes. Thank you for the hearts. Thank you for the hearts. When I talk about diabetes, I always say a lot of people are so focused on this aspect of the sugar, right? Like it's always about the sugar. Like they're always worried the sugar. And I tell people all the time, diabetes is one of the most severe vascular diseases that we know of. And it's a disease I wouldn't even wish on my enemy, right? Like I would hate for my enemy to have diabetes because there's so many, well, maybe not too much, right? But there's so many different ways that it can affect you outside of just high blood sugar. Like, of course, obviously, when we think about diabetes, just our first thoughts is, all right, the blood sugar. But what the biggest issue, of course, is just all of the damage that can occur even when the blood sugar is, and this is what might be crazy to hear, even when the blood sugar is pretty controlled, right? So if you can kind of catch the top, DJ Mister Cee, cause of death revealed as diabetes-related coronary artery disease and kidney disease. So Mr. Cee was a famous DJ, one of the pioneers, especially, if you're a fan of hip hop, one of the pioneers of hip hop and just rap music in general. So a significant person. And of course, when he passed away, a lot of people were sad. And what typically happens, right? Like our despair becomes intrigue, especially when it's a celebrity. I hate that it's like that. I do hate that it's like that. But whenever we hear that a celebrity dies, we're sad that the celebrity dies, but we also want to know why that celebrity died. So of course, when this popped up and, it said, complications, diabetes, coronary disease, kidney disease, a lot of people were like, whoa, hold on now. How is it that you can start out, just with the diabetes and then all of a sudden all these problems arise, right? So my quick spiel, this is what I usually tell patients, especially in a hospital setting, especially when I'm doing outpatient medicine. When you think about diabetes and how significant diabetes is, it's and this changes year to year. Number one, number two cause, right, for heart disease. Number one or number two cause for chronic kidney disease. Number one or number two cause for blindness in the world. Top 10 cause of death here in this country. It takes about 100,000 people plus people die a year more worldwide. Peripheral arterial disease, so patients who end up on dialysis or end up having amputations, diabetes is the number one cause for it. So again, this is not a disease where we're just talking about the sugars. When I talk to my patients, especially my black patients, a lot of times they hear the sugars. That's always a big thing for them. Especially because when we start talking about the treatment options for diabetes, we always focus on the diet. Of course, the diet has to be an issue because diet, plays a significant factor. But when we talk about diabetes, recognizing that the damage that can occur not only, and then for my men, right, especially, may not, try to avoid us, right? Think about from a vascular standpoint, think about which organ needs a lot of good blood flow to work very, very well. I want y'all, I'll let y'all put two and two together. Think about which organ, needs to work needs a good amount of blood flow to work very, very well. If you are a diabetic patient and you have, in fact, a lot of times when you guys are coming to the office and you tell us, hey, that organ isn't working for me, I don't know why. One of the things we're going to look for is making sure that, you're not, a closet diabetic, right? Or some type of vascular disease, right? Because again, it's an organ, it needs blood flow. So if there's a trouble getting blood flow to that area, guess what? That organ that you love is not going to work. So understanding that, yes, we will attack a person's diet, right? Like we go after the diet. We're like, all right, we gotta fix what's you putting in your mouth. But it don't matter, because like now you can have great blood sugars and still have all of these other issues aside. So again, and again, he was 57 years old. This is a young guy. And more often, especially in the African American community, more often we're having our younger and younger adults pass away from diseases that should just be chronic in nature, but they are passing away from these things. Like whether we talk about hypertension, whether we talk about cholesterol, definitely we talk about diabetes. More and more deaths are affected, especially in our community, at such a significant rate, right? I got, you know me, I like my numbers. This is from the American Diabetic Association, right? Just so we have a good idea. About 12% of the population has diabetes. 12% of the population diabetes. 38.4 million adults with diabetes. 29 who are diagnosed. About 9 adults are running around here, don't even realize they have diabetes. A lot of people are walking around here not even recognizing that they have diabetes. So again, you have this disease that's causing problems, and typically, especially for adults, it's one of the diseases that's chronic in nature, that kind of creeps up in nature. You're not necessarily sure why the problems are arising, but all of a sudden you go to see someone like me in the office, and we do our regular blood test, right? And we're going to talk about that. We do our regular blood test, and then boom, like, oh, by the way, you're a diabetic, right? Like, did you know that and you're taken aback because you don't understand it. Because especially for my undiagnosed diabetics, and what we'll do, let's give a scenario of what typically happens when you come to the office, especially when your diabetes is uncontrolled. You're a diabetic patient, but you don't know you're diabetic. Some of the common symptoms that we kind of talk about, and my med students will know this, we call it the 3 Ps, right? So you drink a lot, you pee a lot, right? You lose some weight, right? You eat a lot, right? So polydipsia, polyphagia, polyuria, right? So you are peeing a lot, you're eating a lot, you're peeing, eating, urinating a lot, right? But you don't know why, right? And we're going to talk about why. So, of course, you come in and I hear those symptoms, right? I go back to medical school. I'm like, oh, I know what this is, right? But, of course, I got to play it cool. Like I don't know the answer. And this is what typically happens in the office, right? Your doctor got to play it cool like they don't already know what the answer is. So we got to spend an extra 13 minutes. Like, all right, like I got my answer in 2 minutes, but let's spend this extra 13 minutes to kind of figure out what else is going on. So you come in and you say, doc, I'm eating everything in sight. I can't gain no weight. In fact, I'm losing weight like crazy, and I can't stop going to the bathroom. So what is happening here, right? So what is happening from a physiological standpoint? One, right, the amount of carbs that you're taking in, right, which would normally satiate you and fill you up and keep you moving, right, does nothing for you. Why? Because your diabetes is so uncontrolled. Guess what? You are just peeing out all of those carbs. So, and we talk about low carb diets. Guess what happens on low carb diets? You tend to lose weight, right? So all of those carbs are just being peed out, because your body's like, hey, I can't deal with all of this blood sugar in the system, so I'm just move it out of here. I'm going to run it through the kidneys, which sometimes chronic kidney disease will damage the kidneys. In doing so, I'm going to run it through the kidneys, get them out of here. Right. And then just figure out like, hey, I don't know what you're going to do. And of course, you don't realize any better. You haven't seen a doctor in a few months, right? Maybe a few years. So you just keep eating, keep drinking, and it don't matter, right? Eating, you're drinking, you're peeing. You're eating, you're drinking, you're peeing. You're eating, you're drinking, you're peeing. Right. And of course, you run into someone like me and I say, oh, you know what? I think you might be a diabetic, but let's check. Right. And we'll do some blood tests, right? Typically, one will check, obviously, the standard. I want to make sure your kidney function hopefully is okay. A lot of times, and unfortunately, I've had patients where I've diagnosed patients with stage 3, stage 4 chronic kidney disease, and that's the stage before you need dialysis. And then all of a sudden, like, I got to send you to the kidney specialist. And that's the first time they see me because their diabetes has been so effective in that regards, right? And we're definitely going to talk about it. I see y'all questions. I love them. Then you come and I got to do some blood work. So I'm going to check your kidney function. The biggest test we typically do was our A1C. What does our hemoglobin A1C does? It says, hey, you know what? I want to see how well your blood sugar has been controlled for the past 3 months. I want to see how well your blood sugar has been controlled for the past 3 months. And you know, because sometimes patients will lie, say, oh, doc, my blood sugars are good all the time. Then I do that test and it's your blood sugars have clearly not been good all that time. So it will give me a pretty much an average based off what your sugars have been just over the past 3 months, right? And the numbers have changed over the years, especially when I started out of residency. You had to have a hemoglobin A1C above 7 to be considered diabetic. Now we moved it down to 6.5. Why? Because we want to catch people earlier, right? We want to catch people earlier before they get to the point where they're having chronic kidney disease and coronary artery disease. So you have this issue where, like, boom, now you're a diabetic. You know that you're diabetic. What do we do, right? And I saw some questions like, all right, like, what am I supposed to do here? One, we got to figure out what's the cause of it. Someone mentioned on the comments like, hey, insulin resistance, what does that mean? So it typically happens, especially for my type 2 diabetics, and these are my adult diabetics. Oh, very good question about 6. Oh, I love that. Y'all asking some great questions tonight. Type 2 diabetics. What typically occurs with my type 2 diabetics is that reason why it's adult onset related is that you have some insulin in your system, but it eventually gets burnt out. Like a person who isn't diabetic, they don't have a process of their insulin being burnt out. But a person who is, yeah, it actually gets burnt out. And when it gets burnt out, guess what? Now it can't deal with the sugars. Oh, hold on. It can't deal. Oh yeah, it can't deal with the sugars that you are dealing with, right? So then that's when you get the peeing out. That's when it gets uncontrolled, right? Versus my kids, right? The reason why we typically will find our type 1 diabetics, the ones who have no insulin whatsoever, because if you have no insulin whatsoever, we know that when you're a little kid. Like, you're not walking around with type 2 diabetes as a little kid because you would have already ran into a problem when you're like usually the teenage years, 10 to 15. 10 to 15 is usually when you get your first diabetic crisis and say, oh, your sugars are out of control, right? Someone mentioned DKA. It is one of the hospital-related emergencies that has you coming to the hospital, that gets you admitted to the hospital because you've got to the point where your sugars have become so high, you have become acidotic in state, right? Like your body, and again, because especially for my alkaline drinking folks, right? Like your blood pH becomes acidotic in nature, right? To the point where I have to give you an insulin on a drip. I have to give you a whole bunch of fluids. Again, we're not going to go into too much detail about DKA, but it is a problem. Shout out to, appreciate the lightning bolts. Appreciate the lightning bolts. Like, so definitely an issue of concern when it becomes an emergency, right? So let's go back, right? So yes, now you're a diabetic, right? Your A1C is, let's say, 8 or 9, right? What do I do? First thing we always do, obviously, we get our good history. We know whether you have family history of diabetes, right? Because that's a very common cause of it. Family history of diabetes, for sure. Obviously, race plays a factor, right? Because we know race, genetics plays a factor. Of course, we're going to ask about the diet. Any medications that could play a factor in burning out your pancreas, which affects your insulin. Once we kind of get those historical questions, now it's the intervention time. It's intervention time because, again, these are the numbers, right? Just based off, rates of diagnosis based off race and ethnicity. 13% American Indians, 12% non-Hispanic Black adults, 11% Hispanic adults, 9% Asian, about 7% whites, right? As far as who gets diabetes, right? So there's racial components in it, genetic components, depending on where you study, but like, typically, there's not like, all right, women definitely get diabetes more than men. There's not, you don't necessarily see that. It's usually more of a dietary or genetic factor than, your genetics playing a factor. Some hormones more often than not. And then, like I said, we already talked about eighth leading cause, and then it costs us a lot of money, right? So you get to this point here where, you know what, this thing is costing us, this is causing a lot of problems. I got to do something about it. Of course, diet is, right up the top, right? Diet is, because one, we got to figure out, all right, what are you eating? What are you eating that is causing an issue where your system is overloaded? And again, we haven't touched the medication yet. We haven't even gotten to that medication yet. What are some of the foods that you're eating? Or what are some of the foods that, maybe you need to eat less of? Or on the other hand, typically what occurs, eat more of that can try to allow your body to kind of, help you deal with the fact that your insulin isn't working as effectively as it does, right? So let me get some questions here. I don't want to go too far while I get into the questions. Let's see. Fast sleep, move more, stress, everybody's trying to heal themselves. They can, but again, like I said, it's so I like this, right? Because again, this kind of goes to, and because we're gonna get a lot of comments that kind of go to, kind of the natural aspect of it. Yes, there are some natural things you can do to help, right, with your diabetes. But if your insulin levels are shot, your pancreas is shot, you can sleep all you want. You are not going to be able to control your blood sugar, right? You can exercise all you want, not going to be able to control your blood sugar, right? So, but it is important, right? We don't, and I think this sometimes get lost, especially in healthcare when we're dealing with, when we kind of talk about interventions. I think a lot of times because we don't necessarily say like, natural and exercise and do that stuff, people assume we don't want you to also do that things, right? We like that. Is there like lifestyle changes, modifications? That is sleeping, eating more, working out. That's all that's included, right? So we want to make sure we don't neglect that. But once you get to that point, when you need interventions like changing your diet, you need interventions like medications, like you can't run away from it. Let's say, oh yes, She's Beautiful says, uncontrolled hypertension, diabetes, biggest hit on your kidneys, for sure. Like it's number 1, number 2 cause. And it will be pretty much probably for the rest of our lives, right? So when you have a patient who is on dialysis and you ask them about their medical history, yes, there's going to be some familial history or some genetic issue that may associate with their chronic kidney disease, but 8 times out of 10, diabetes or hypertension will be in their history. 8 times out of 10, right? So definitely a great point there. Let's see. How can I tell? Oh, Gabrielle, I'm not sure. I'm not sure which part. I apologize, I missed this. I'm not sure which the date can tell. If you could just ask your question again, I'll definitely get to you. Someone says, this is a great question, right? So someone said, does sickle cell trait affect your A1C? I love this question. Reason being is because when we're talking about the A1C, the test that they do is that they will actually measure your red blood cells for the past 3 months. Those who know about sickle cell disease, right? And I know we've talked about this, but we might even need to talk about that next month, because I feel like Sickle Cell Awareness Month it might have passed or it's coming up. Like it's usually around this time frame, I think. Because you have misshapen cells, guess what? The tests that are typically for an A1C is going to read it differently, right? So I do love this question as far as affecting the A1C. And typically when you have that, we typically have to do fasting blood tests. And there's other blood tests that we can do that you being sickle cell won't affect it. So definitely a great question there. Let's see. 6.8. Oh yeah, so 6.8. Oh, so She's Beautiful. Good. So this is a good question, right? Like and this is in regards to the A1C. When do I have to give you insulin? Now, let me tell you. At 6.5, you are diabetic. I can assure you, and again, just from practice, right? If I tell a patient, hey, your A1C is 6.8, let's start you on insulin, they're gonna fight me. They just are, right? Like they are gonna fight me, especially if this is my first time seeing you. Because we have options before we get to insulin. So if I say, hey, I'm about to get ready to start sticking you at a 6.8, no, they're going to fight me. So usually we will try to, that's when we kind of mentioned earlier about the intervention, sleeping more, less stress, changing your diet, exercise. That's the area 6.5 to 7.5. Probably 7 is where we're really going to try to hit home those interventions, because I want to try to avoid putting you on pills, right, for diabetes. We got a lot of them. I want to try to avoid putting you on those things here, but I understand that let's say that number was 7.8, 8.8, then you start getting to a point where, like I said, we can sleep all we want, we can de-stress all we want, we can change our diet all we want. I'm likely not going to be able to take your 7.8 down under 6.5. Just doing those things. Most likely, again, not just, especially because I don't want someone to, because I know there's a lot of TikTokers out here, right? Especially my nutritional TikTokers. Even I actually want to try to get somebody on the podcast to talk to them about that, because I just got questions. So I don't want y'all to say, oh, I had this one person who 8, and then they drop their A1C to 6. Yes, that can happen. For the majority of the public, that don't happen. There's just, like I said, I take care of the majority of the public. A good wide range of it. That's usually not the case here from that standpoint. But I love it because we do have to start thinking about insulin. But I let them know. I say, hey, you know what? You are diabetic right now. I almost say it not necessarily to scare them, but say, hey, you know what? We're going in a direction where if we can't really control your blood sugars the way we want to control your blood sugars, we might have to lean this way. So I kind of let them know that insulin may be around the corner. At 6.8, we try to do more lifestyle modification because I don't want to scare them more than anything else. Fat. This is a good question. This is a very good question, right? My fat, and this is kind of from a dietary standpoint. For those who do fasting. So for those who do fasting, if you're unaware of fasting, and it depends on the type of fasting you're doing, the hours you're doing, but like what typically happens, and from a layman's standpoint, is you allow your body to go through kind of a reset period where your body's able to break down all of the carbs that you've eaten, all of the fats that you've eaten, and kind of allow it to go into a little bit of a ketogenesis, right? And that's kind of what happens with our low carb diets. So you do have patients who, there's even in those studies where those people who actually fast, and this is where they may eat 8 hours of the day and then have a 16-hour fast, or 12 hours a day and have a 12-hour fast. Like I know some people will actually reset their body and do a 24-hour fast. Good luck, right? Ain't me. But like I said, I just know some people who do that. So intermittent fasting is definitely a good way at controlling your blood sugar, because typically you have less spikes occurring because one, you're usually not eating and your body knows how to kind of deal with it. So it is an option. Of course, obviously you want to make sure you're doing, especially if you're a diabetic patient, you got either a dietitian or your doctor or someone just kind of watching over you just to make sure your sugars aren't fluctuating crazy, but it isn't out of the ordinary. Because I actually have a couple of patients right now who that's what they do. They do intermittent fasting, and they've noticed that they have less blood sugar spikes because they intermittent fasting. They know when they're going to eat. They know when they're not going to eat. And guess who also knows? Their brain and their body knows when they're going to eat, when they're not going to eat. So it becomes extremely beneficial for them as well too, right? Yeah, pregnancy is definitely a good one. There's a lot of people who they may have a family history, may not, but because they get pregnant, then they develop gestational diabetes from the pregnancy. And then even when the baby is gone, right, a lot of them, the gestational diabetes goes away, but some of them, like the diabetes kind of stays around from that standpoint. There's quite a few people who are in that front as well, right? So somebody's talking about type 2 diabetic. This is a good question, right? Especially for type 2 diabetes and kind of diet related, right? What typically happens, right? And this is I usually teach my medical students and residents, right? Because when they're trying to figure out especially disease processes like DKA and HHS, right? And these are medical emergency related concerns, right? As far as you in the hospital, right? Like, how do I know a person will develop DKA, right? Diabetic ketoacidosis. That's type 1. Reason why it's type 1 is because you typically have no insulin whatsoever in your body, and then you have high blood sugars. Now, high blood sugars may be 400, 500, which again, it's definitely high. But when I talk about HSS, right, that is the type 2 diabetic component of emergency. Their numbers may be 600, 700, 800, right? Your DKA patient will never have a sugar that high, or they're not living, right? Like if it got that bad, it's a severe problem. But if you have a blood sugar, especially coming in a hospital, your blood sugar is like 800, 900, you're likely going to be this hyperosmolar hyperketotic syndrome. That's HHS, right? And because what typically happens is you have some insulin just there, but it's just not enough to deal with, if you get illness, if, typically medication effect, like it's just not enough to deal with that aspect of it, right? So typically your type 2 diabetics, the reason why they call it like diet related is because your insulin essentially kind of burns out, right? Like, you've been chugging along for 20 years, 25 years, 30 years. And it's been enough until it's not enough in that regard. So yes, you still have some insulin. You have a little bit of it, but not enough to meet the demands for what you typically eat or drink. And that's when you typically need some type of supplementation, whether it be oral pills or, the insulin, which I know a lot of people are aware of. Sickle cell. Oh, yes. I love it. Sickle Cell Awareness Day. Let's give a shout out to Sickle Cell Awareness. Sickle Cell Awareness Day, because we had mentioned it earlier. Sickle Cell Awareness Day is June 19th. Month is in September. I knew it was like sometime in that regard, right? Because sickle cell awareness is just one of these diseases that, obviously, especially because of the community I typically take care of, obviously it affects, African Americans at such a significant rate. And the stigma that our sickle cell patients have to deal with, especially when they're in the hospital, in their emergency room, when they're in crisis, is so disheartening. That you have to be very proactive for them, and you have to be a very, strong advocate, because, they live in pain. Our sickle cell, like I said, I hate to delve into sickle cell rant, but like they live in pain to the point where when they go to the hospital, people don't believe that they're really in that much pain when they really are, right? So, definitely a good point, and we'll definitely make sure I'm making a note to talk about sickle cell when that comes about. Let's see here. Let's see here. Oh, so this is she. So metformin, right? Metformin it's the gold standard in pills. An oral. It's the first line medication, as long as you don't have no kidney issues. First line medication for our patients who are on diabetes. It's a great drug. It's the gold standard drug, but you got to be compliant. You got and that's really with anything, right? If I have a blood pressure medication, if you aren't compliant with your blood pressure medication, guess what? It ain't gonna really work. If you are compliant if you're a diabetic, you're not compliant with your diabetes, especially with diet, exercise, and then the medications like a metformin, not gonna work. But metformin is one of the gold standard medications. All oral pills that come out for diabetes always gets compared to, hey, how do you compare to metformin? Right, just for just so you understand, metformin is the gold standard. Again, not everyone could be on metformin, because if you have chronic kidney disease and creatinine levels that are abnormal, you can't even be on that type of medication. But if your kidney function is normal, it's usually one of the first medications that you need to be on there. Hey, Corey, how you doing? So shout out to Corey, who, for those who may not know, my wife is the founder of Autism in Black. And Corey was such a significant portion. It won't let me pin you. That's annoying. So her contribution to everything my wife does, but specifically for that conference, I've been talking about it for 2 episodes. My wife, we just recorded my wife's episode of her recap for the conference today. We actually recorded today, but it don't come out till next week, I think. She's phenomenal. So she's definitely one, especially for my content creators out here. If you need someone to kind of run the back end stuff for you, social media promotion, business, she does it all. She do a whole bunch of stuff for my wife. Definitely one I suggest you follow for sure. Let's see here. Let's see. Oh, she's beautiful as a nurse practitioner. Shout out to. I'm gonna make sure I follow you when I'm done here. I love my nurse practitioners. I love my nurse practitioners here. Someone said my A1C was an 8. They gave me Jardiance. Yeah, it's a very good medication. Very good oral medication. Usually very well tolerated. With very minimal side effects, as long as you're taking it, as long as you kind of keeping an eye on your blood sugars. And it's just one of those good, like I said, especially again, that's why we don't go straight to sticking you with the insulin, because we know. I just know, especially for my men who's never, seen a doctor maybe in 3-5 years, and now I tell them they're diabetic. If I tell them they're diabetic and their A1C, even if their A1C is 7.4, 7.5, they're going to fight with me right off the get-go. I usually have to convince them to do insulin. So we definitely try oral pills. Jardiance is definitely one of those good ones that we do. How do you know what are the symptoms? Yeah, so typically what happens, especially for our patient who is not diagnosed, you don't have a diagnosis of diabetes, the symptoms that we typically are looking for is, hey, have you lost significant amount of weight without trying? Like if you lost weight without trying, if you're going to the bathroom all of the time, you're drinking everything in sight, you're eating everything in sight. Like we start looking for things, and because your body is saying, hey, I can't handle the glucose that is coming into my system. So I'm going to pee all of it out, right? And when I pee all of it out, guess what happens, right? I get dehydrated, so I drink more fluid. Not only that, because I'm peeing all of your carbs out, you're losing weight like crazy. You didn't even try, you're just losing weight like crazy. And then you're just eating everything because all of the food that you're eating carb-wise is just getting peed out. So that's how we will look at it from our standpoint. Now, of course, obviously, we're going to ask for family history and all those things there. But one of the more common scenarios for our first-time diabetics will be those symptoms. Now, of course, right? Sometimes we catch them late, and all of a sudden, the first time I see them is because they've had a heart attack. First time I see them because they've had a stroke, right? Like that. Sometimes that's a first time as well too. We never, and that's why we like to talk about it when something like this happens. Because I never want to be the first time you realize you have medical disease is that I got to see you in the hospital. Right? Because some emergency happened, right? We talked about DKA, right? That's an emergency happened. HHS, that's an emergency. Like I want hopefully that someone catches you early enough so that never becomes the case, right? But again, we live in reality, right? I tell my medical colleagues this all the time. Like I live in reality. Like, yeah, that's cool that in the books that a person is going to come to you and, you're going to follow them up appropriately. And, you're going to see them before they get to the point where they need to see the kidney specialist and the heart specialist because that's cool to say that. But in reality, that just don't happen because we know, kind of structural racism, just lack of access to care, lack of finances, because again, a lot of people, especially in this country, are just one paycheck away from disaster, right? So they definitely don't want to see me. Right. And I tell them you got hypertension, diabetes, high cholesterol. You got to pay all these. Like, nah, they don't even want to address those problems. So they're going to avoid our medical system until our medical system kind of finds them. So those are the typical symptoms from an outpatient standpoint that will typically occur. Right. And again, the reason why it's important that we try to catch it early is because we know that if it's uncontrolled, your diabetes is, we're just talking about diabetes. If your diabetes is uncontrolled, we know that you can have, especially for my men, you can have erectile dysfunction issues. You can have vision-related issues. Quite often, people are getting their eye exams and their optometrist telling them, hey, I think you might have diabetes. They're going to the dentist. They have poor oral health. Their dentist is saying, hey, you know what? Have you ever been checked for diabetes? Right? So a lot of times, it's our other specialists who are seeing things that say, hey, you know what? You might be a diabetic because your teeth is pretty bad or your eyes are pretty bad. That's usually the case here. That's usually the case for a lot of people, when they're a newly diabetic and they're just because, again, we have a lot of people who are walking around with undiagnosed diabetes and it's because of those symptoms there. Very good, very good question. Sure. Let's see. Yeah, so Yolanda says her brother was a local DJ here in Texas, was diabetic, non-compliant. Yeah, it's, and I hate to say it, it's killing us, right? It is killing us because of the complications, right? Because of all of the things that, and again, it's not, yes, the sugar is high. Yep, that's the issue. But it's killing a lot of us at such a young age, right? Because we're walking around acting like it's not a problem, right? And then, like I said, any person who's had any amputation, toe amputation, foot amputation, below the knee amputation, diabetes is usually right there, right? Some type of peripheral arterial disease is usually right there. Diabetes don't typically, follow very far behind. You're on dialysis, you're likely a diabetic or a hypertensive patient, vice versa, right? So it's definitely a continued issue that we just need to kind of scream from the rooftops. Because imagine if, I could have just gave this person this oral pill, right? Metformin, Jardiance, glipizide, glyburide. There's a lot of oral pills. There's insulin. I could have just gave you something right here and I could have prevented all of these other issues downwind. But because I couldn't get to you when I needed to get to you early, you develop all of these issues at the later tail stage by the time you see us, right? Which is always, the problem at hand. A1C 5.4, that is very good. Very, very good. Weight loss with metformin. Yes, you can have some weight loss with metformin. Now, what typically happens, and again, a lot of it just kind of goes in combination of you doing very well with diet, and you now being able to, process, metabolize the carbs that you're getting in appropriately, and then the weight loss tends to occur. Now, again, you can have weight loss with uncontrolled diabetes, but if you get your, and again, that's why metformin is one of the gold standards, right? Because not only is it pretty safe, as long as your kidney function is normal, but you can have some weight loss associated with it, right? Like if for those who I know you guys probably seen this Ozempic, right? The Ozempic and Wegovy or Mounjaro. Those are diabetic medications, right? But like subsequently, they kind of realized like, oh, this diabetic medication, a lot of people happen to be losing weight, so they flipped it and said, hey, let's see if we can just market that as a weight loss drug. And then that's how some folks make billions of dollars. But yeah, definitely sure. Corey says, I heard metformin hurts your stomach and it's hard to get off. Oh, see, this is a good question. So one of the things with metformin, especially when you're first starting it, and I always prep my patients. Hey, I'm starting on this new medication, especially because usually you're on nothing. I'm starting on this medication here. You are going to have some GI related, it's just not going to feel well. And that's just your body trying to get used to this new medication that you're on, right? So you're not going to necessarily feel the best. But I always tell them, give me about 4 to 6 weeks. And you have to tell patients this, right? And this, I always get on my colleagues because they don't. And then their patient comes and says, oh my God, I keep having stomach aches, or, I feel like my food ain't digesting. I'm getting off this medication. Like if you prep your patient and say, hey, these are symptoms that are likely to occur, but they are short-lived and your body will get used to it, right? Then they're like, okay, doc said that, I'm gonna have some stomach issues. All right, I'll just kind of deal with it. But yes, definitely for sure, it's common to have GI-related upset issues, especially on the initial. Now, typically, if you can get past the 4 to 6 week mark, usually your body kind of gets used to dealing with metformin in your system. But it does and can cause. Now, again, it doesn't cause it for everybody. So I don't want, because I know there's always didn't do nothing for me. Yes, I know. It doesn't cause for everybody, but it does it for enough people that if you prep your patients early enough, you're definitely good to go. Someone said let's see, make sure we don't. Let's see, orals for type 1. Yeah, type 1. Yeah. Oh, this is a good question, right? And this kind of goes back to our type 1 versus type 2. Our type 2 diabetic has some trace of insulin in their system, right? They just don't have enough to deal with. They don't have enough to deal with what? They don't have enough to deal with what you're eating or drinking or whatever, right? So because they have some in your system, you can supplement that with the orals. If you are a type 1 person, that means you got nothing, right? These are the ones we diagnose when they're young, right? This is the kid. You got no insulin whatsoever. You need insulin, right? There's no question you're getting insulin. But like I said, you're going to get insulin as a kid because you likely already ended up in the hospital because you got into DKA. So yeah, but you can get on insulin, right, as a type 1 and then still supplement that with oral. But you are definitely going to be with insulin. You're not running away from needing insulin if you are a type 1 diabetic. Type 2, we can give you some oral. Type 1, for sure, you're getting insulin. No questions about it. Don't care what your A1C is from that standpoint here. Someone said, let me see. Let's see, make sure. See, I like these questions, right? So Key says, Western medicine is horrible. The physicians are not like they used to be. I don't know how the physicians were in the past, right? But I could understand why people may feel this way, right? And we talk about this all the time on my channel, right? That there is a current mistrust with just healthcare in general. Really, there's a current mistrust with just experts in general, but especially with medicine, right? We'll just keep it medicine right now. There's a current mistrust with medicine in general. So what's in Western medicine? Right. So what typically happens is that you have a lot of people who are looking, and this is why they call it alternative medicine, right? Because they're like, I need to find some alternative way, right? So I don't have to go with what they consider Western medicine, traditional medicine, whatever category they put that medicine is, right? So, and again, I'm not mad at you for doing it, right? I tell people all the time, like, yeah, like go look for supplements, right? Go look for, vitamins and supplements and all of these things here. But like you'll see the people again, I love it because people who are typically very like anti-Western medicine, right? Are very religious to the vitamins and supplement industry, right? So whatever industry you choose to follow, as long as it's getting you long as you're getting healthy, right? Long as it's keeping your sugars in control. Like if you need, what are some good ones? Turmeric. And again, I'm just shooting off the breeze. I don't really know, right? And I always tell people all this time, those who train in I guess Western medicine, right? Like we don't go to class learning about supplements and vitamins and everything else. Right. So a lot of times the education that we have to get, right, is a supplement that we have to go out and get extra supplement, right? Like I have a lot of friends who are natural NPs, like naturopathic physicians, right? That's what they do, right? Like they don't really go on our side. Like, they go through the naturopathic way of doing it. That's we just want you healthy. However you get healthy, by all means, rock out. Like if it's Eastern medicine, supplements, turmeric, sea moss, I don't even know the vitamins A through Z's, whatever the thing is, as long as at the end of the day, and that's why medicine is great, right? Because medicine is very individualized, right? The goal is to make sure you are getting healthy. So if you're getting healthy, going the non-Western way, like no one should, right? I ain't gonna say no one will. No one should tell you that that's a bad thing, right? Like I said, there's a lot of people who go the Western medicine way and they do fine as well too, right? So I do love both, especially if you can get a great combination of the two, for sure. Bree says, first of all, yeah, shout out to Walmart. Walmart has a great medication list of medication just in general, but especially for our diabetic patients, especially because, cost is definitely an issue. This is a good one. For women, frequent yeast infections could also be a sign as well too, right? Now, y'all know me, I'm an internist, right? So I tell you, I don't, I like women's health from afar, right? But I always defer to my OB-GYNs whenever it's go time day. Let's see here. It's a very good question. I'm in South Florida. I am in South Florida. I changed my diet immediately after being told I was pre-diabetic. Yeah. No, shout out to Nisha. Nisha said, yeah, she said she switched her diet up quickly, right? And again, and we don't want to scare you, right? Again, even this right here isn't necessary to scare you. It's just to kind of educate us, right? Because a lot of us have family members who are in their late 50s, and obviously I'm weird, right? I'm a physician, right? So I'm gonna ask my mom. My dad passed away. I'm gonna ask my uncles and everything. Hey, what's your health look like? Like diabetic, hypertension. I want to know that. Oh, shout out to the Roses. I appreciate you. Right? I want to know how healthy are you, because I know that my uncles and my aunts and my mom and then my grandma, their health plays a factor in my health as well. Right? So I want to know, hey, what's going on with you? Right? And a lot of us don't typically do that. So a lot of us won't even know that grandma, grandpa got diabetes, hypertension, high cholesterol, breast cancer, colon cancer. We won't even know these things. And we just kind of walk around them all day, not realizing that it definitely can play a role in just our level of health, right? So a lot of it is just, making sure, we're educated and recognizing, all right, what are some things I can do to prevent any, late stage effects, right? Again, when you talk about diabetes, coronary artery disease, kidney disease, these are late stage effects of having it for decades, not like 1 year, 2 year, decades of damage that's happening to your body. I love this here. Let's see. Yeah, there's a lot. It's a good question. Is metformin okay to take long term? Yeah, if your blood sugars remain controlled, and your diabetes, you're in check, your sugars are in check, you're exercising well, it's a very safe drug to just take. There are some studies that talk about the benefits of metformin in delaying neurovascular related diseases like Alzheimer's and Parkinson's. There's some diseases that talk about the association of having metformin and cognitive impairment, right? Like if you're on it, you can have less risk of it. Now, again, it's one of those things where, all right, is the association direct? No, right? Because obviously you can't do like a study that says, hey, I'm going to put these patients on metformin for 20 years, these patients not on metformin for 20 years, and I want to see if they get dementia, right? But there's association that these patients who might be on metformin may have less of a risk of developing cognitive impairment like Alzheimer's and dementia, right? So it is one of the things, yes, I have a lot of patients who will be on that for a long period of time. Good question. Do naturopathic physicians go to medical school? No, they don't go to medical school. They actually have naturopathic schools for them, right? I had, oh my God, she is going to kill me because I cannot think of her name. Because I had a naturopathic physician on the podcast. Oh my God, it's going to kill me. So you know what? Because I can't think of the top of her name, I'm going to have to make sure I get her back on the podcast or a natural, just so they can remain fresh in my mind. But yeah, no, they go to their own school, own residencies. And like I said, again, that's why it's not a competition thing, right? Like if the naturopathic way is getting you healthy, rock out. Eastern medicine, getting you healthy, rock out. Sea moss, turmeric, all this other stuff, rock out. Like whatever is getting you healthy from an individual perspective. Because again, medicine has never been a one size fit all type thing. We just know that, I just teach from the Western side of, like, hey, this is what we have to do from a level of care standpoint. Let's see here. Someone says dark line. Oh, no. But this is a good question, right? Because there has some people, right? This is the darkened line on your neck a sign? No. But there are some skin changes associated with diabetes, right? Now, again, you're not going to walk around and be like, oh, I think this person has diabetes. Not the case right there, right? But there can be some skin changes. We kind of mentioned some patients will develop, increased risk of, tinea capitis, fungal infections, everything else. But it's not like oh, I think that line right there, or I think that mark right there means that your diabetes may be uncontrolled or something like that, right? Because like my A1C is actually like amazing. But that's more genetics more than anything else. There ain't really nothing that I'm doing. I got good genes. Should I take losartan for chronic kidneys? Oh, should I take losartan? So losartan is a blood pressure medication, and asking, should I take it for chronic kidney disease stage 3? Now, of course, obviously, defer to your physician, right? But like what we tell patients, especially for those medications, reason why that's a good question is because the way losartan works is that it affects the kidney system, right, to help decrease your blood pressure. So when you're on those types of medications, losartan, lisinopril, ones that we know go through the kidneys to work, obviously we want to make sure that it doesn't cause damage to your kidneys. So as long as it's not causing damage to your kidneys, it can be very well tolerated. You typically get in trouble, especially stage 4. Patients where it may cause more harm than good, but it is something that you want to kind of keep track of. Very good question. Let's see here. Let's see here. Can you speak on LADA versus LADA? Okay, I'm not familiar with LADA. Let me see if I can Google what that acronym stands for. LADA versus diabetes. Oh, autoimmune. Okay. Latent autoimmune diabetes in adults. Type 1 starts with adults, slowly gets worse over time. Happens when the pancreas stops making insulin. Right. So yeah, this kind of operates in that same ilk of your adult, right, whose insulin essentially kind of runs out in that regards, right? Versus your type 2 diabetic patient will have some insulin there, just not enough, right, to deal with the onslaught, right? Whereas LADA is like, hey, you know what? We've ran our course. I'm not making no more insulin. Boom, we crash it, right? And again, if you get to that point, guess what? You don't have an option. You need some insulin. You definitely need some insulin for sure, right? Very good question. How do I get training in naturopathy? So there are actually, and again, I'm not the expert of it, right? When I talk to her, there are, just like, when you get your bachelor's degree, there are actually schools that you apply to, just like you apply to medical school I don't want to say like you need certain majors because you probably don't, right? Probably, if you're science, if you got the sciences, you're probably good to go. But it's just like now, obviously there's not as many schools as there are med schools or dental schools in this country, but there are enough schools here, to get your degree in naturopathic medicine, and they do residencies as well. So for those who don't know, in medicine, we go to medical school 4 years, and then after we decide, hey, I want to do this specialty, right? And then we go and then we do a specialty for 3 years, 7 years, however long. So naturopathic physicians also go to residency after the fact as well too, right? So like I said, I love my naturopathic physicians. I'm so mad that I can't think of her name. I know she's gonna kill me. I apologize if I remember. I do apologize for it. Let me see here. Amlodipine is a good blood pressure medication. Oh, yep, shout out. So and there's let me shout out. And as a hemodialysis nurse, right? So, as a hemodialysis nurse, again, she typically, unfortunately, deals with our late stage patients, right? Whether it be due to hypertension, high cholesterol, some type of kidney related, issue could be, intrinsic in nature. But again, she deals with a lot of those patients, and I'm pretty sure Anna can tell you about, from a percentage standpoint, how many of them either have that diagnosis of hypertension, or high blood pressure or high cholesterol. Let's see here. What about urinating a lot every 15 minutes, swelling feet? Tara says, what about urinating a lot every 15 minutes, swelling feet, chest pains, wheezing, breathing? Well, that's a lot. That's a lot, right? So, if you were just coming in the hospital, right, and you told me those symptoms, one, I'd be concerned, right, just for swelling of the feet. Just for the fact that you're peeing a lot, that you've probably fluid overloaded, right? So I'm already concerned that you're fluid overloaded. Typically, I'm gonna get a chest X-ray, be concerned about, medical history of like CHF or something in that regards. But that would be my concern, right? Like if you are peeing a lot, now again, it could be a couple things running at the same time. You could have enlarged prostate, right? Like if you're a man, enlarged prostate, and that could be causing you to urinate a lot. But if I had to deal with all of those symptoms at once and make a educated guess on your likely diagnosis, that is going to be the first thing I'm thinking about. Like, oh, are you in like heart failure, right? Because not only is the fluid backing up so much that it's causing you to wheeze, right? Because you can't breathe because there's fluid in your lungs, but it's also causing you to have fluid in your legs, right? So you have this fluid that typically your heart pumps, gets fluid out. But if you're having heart failure, meaning that my heart can't deal with the amount of fluid coming in, right? All of a sudden it starts backflowing. It first it backflows to the lungs, then it backflows to the legs, and then problems arise, right? So that would be my concern. Like I said, if I was just guessing, right? This is just like, if I was just guessing, that would be my concern. Hopefully that's not happening to you, right? Hopefully that is not happening to you right now, Ms. Tara. Let's see here. Be kind says, I promise to make you my priority if you marry my daughter to get out of the house. That's too funny. Too funny. Rich Lifter says diabetes causes heart issues. Oh, for sure, right? Because if we just think about it from, just because like I said, I know a lot of people focus on just sugars, right? And the elevated sugars in the system. But what typically happens is if you have uncontrolled blood sugars, or you have a state where you have an uncontrolled blood sugars, you typically place more stress on the heart to have to deal with either fluid built up, either kidney related issues or concerns, and then in sequelae you start having heart damage, and all of these things kind of play a role to it, right? So it's never a surprise if you have, and typically it's like the three horsemen, right? So you have uncontrolled blood sugar, you have hypertension, then you have high cholesterol, right? So we know all of those things circle around will like portend to you to have some heart related issues of concern. So again, number one cause of coronary artery disease, or number two, depending on which study you read, will always be diabetes. Number one will always be hypertension, or they flip. And it's the reason why, if you look at the top 10 causes of death worldwide, diabetes is always in the top 10. But if you look above diabetes, strokes, Coronary artery disease, hypertension is like in the top 5, right? So I can always argue that, is my diabetes also adding to that stroke? That's number 3. Is my diabetes also adding to that chronic kidney disease? That's number 6 in that regard. So that's always the concern there. What labs should be monitored on BP meds? That's really going to depend on the type of blood pressure med education you're on. We talked about losartan before. Losartan, we know the way it works is that it affects the kidneys. So the labs I'm going to check is to make sure like your kidney function is still completely normal. There are other labs. Let me see. If you're on a beta blocker, it's not necessarily a lab that I'd be concerned about. If you're on a beta blocker, that's like metoprolol. If you are on amlodipine, that's a calcium channel blocker. Again, not necessarily a lab I'm concerned about. I'm probably going to be more concerned about symptoms. If you are on a diuretic, again, that's where the kidneys play a significant role. So I'm going to monitor your kidneys. So if I had to, if we were talking about labs, I'm assuming the type of medication that you're on for blood pressure is going to be one that affects the kidneys, either diuretics or ACE inhibitors like lisinopril or losartan, ARBs. Those would be the ones where I'd be concerned about that I need to monitor your kidneys in that regard. So those would be the most common. Those would be the most common one, right? Oh, thank you. And that is our hemodialysis nurse. She said mostly diabetics, hypertensive, high cholesterol. Yeah, like that 3 monster right there, that three-headed monster right there for a patient can have significant deadly effects. That 3-headed monster right there can have significant deadly effects for prognosis of care in that regards. Thank you, Edna. Because let's see. She is beautiful. She is a beauty. I apologize. She said, where am I? Sorry about that. First, let me just follow you while I got you. So she's a nurse practitioner. CHF is her specialty. So I'm not sure she does cardiology. I'm not sure she does nephrology because I got a lot of nephrologists who like dealing with heart failure, whatever. But so you can tell. So she knows about these heart related issues in that regards. And like I said, CHF is definitely one of those things where it's a problem. It's a problem. So shout out to She's Beauty. Definitely a person you should follow. Let's see here. Make sure. Honey Love says, is it necessary to determine baseline kidney function prior to starting BP meds? If the BP meds they want to start fall in those categories that will likely be treated or be affected by the kidneys, if the kidneys are a problem, for sure. And typically, your doctor's going to get that anyway. Because it's a very baseline blood test that they do, like the BMP. It's going to tell me what your kidney function is. So I have an idea, because that may drive the type of medication I give you in the first place. Like, so if you have good normal kidney function, then I know I have a pretty wide range of medications that I can give you from a blood pressure perspective. So that is something that they typically will give you. Unless they're like, you know what, I'm going to give you like a beta blocker or a calcium channel blocker. And I know I don't necessarily need the kidneys, but normally those docs should get baseline blood work anyway, right? Because you don't want to be just starting a person on a high blood pressure medication and not have a baseline of what all of their other stuff does, right? Normally. Very, very good question there. Let's see. Oh, this is a good show. Oh, someone's nilodipine. So I'm assuming nilodipine is in that same family of the calcium channel blockers. Let's just make sure. Nilodipine. It says nilodipine. I wonder if you're referring to amlodipine. Let me know if because I can't see that medication. I'm not seeing that medication here. So. I know amlodipine definitely for sure, but I'm not necessarily familiar with nilodipine. At least it's not coming up on my searches. Neuropathy. This is a good one too, right? Like another very common issue associated with diabetes is, and we hear about all the time, you can have diabetic neuropathy, right? Which is where you have nerve pain due to nerve damage. Now, unfortunately, right, depending on the severity of the nerve damage, a lot of that could be permanent. Like once you have neuropathy, meaning that, you have less feeling, you have electrical feeling and just numbness, tingling. Once you kind of have that, even when your blood sugars get controlled, that typically don't go away. That's usually not the case from that standpoint there. But definitely a good question. Like, obviously, we want your sugars to be better controlled, but it is one thing that we always have to kind of monitor from that standpoint. Very good question. Let's see. Let me see if we can get another. Cardiology. Ooh, hey, was she? She did critical care too. Shout out to you. Shout out to you. Someone to be normal for someone to be on spironolactone. Now, and when I see this combination, spironolactone and furosemide at the same time, usually they have a history of significant heart failure. Usually stage 3, stage 4. Usually, right? And She's Beauty is on here, so she probably could definitely attest to it. Usually, if you're on that combination, spironolactone and Lasix, as usually it's a 40-20 dosing strategy. Usually, it's a significant stage of heart failure. So no, it is not normal. It is usually my late stage heart failure patients who have to be on that. But She's Beauty is on here. She probably could definitely confirm. But usually, if I see that combination, I assume you either have stage 3, stage 4 heart failure, or you have some liver disease, right? So because the goal is to try to get rid of as much excess fluid as possible, you have to be on those significant medications. And those medications, you definitely will make sure your kidney function. Nifedipine. Yeah, so the nifedipine is a very good medication. It's a calcium channel blocker. Works extremely well. It's a lot of times it's one of the first line medications that I like to use. Now, in the calcium channel blocker universe, you have amlodipine, right? And then you have nifedipine. Nifedipine does very well with, let me make sure about that. So nifedipine does very well with, controlling blood pressure, but it also does very well for our patients who have heart arrhythmias as well. So it kind of helps versus if you're just on Norvax or amlodipine, more blood pressure, related. Good question. I love red yeast and rice for high cholesterol. Because like I said, and this kind of goes back to there are some supplements that we have anecdotal studies that show benefit, right? And red yeast and rice is definitely a good one. I know a lot of people know about the fish oil, definitely another good one as well too. Now the dosing is where people get in trouble because the typical dosing that you need of fish oil is usually a little bit higher than what they give you on the natural supplements. Because sometimes you got to take almost 1.5 what they recommend, but different discussion. But it does work. So yes, definitely a fan of that. Let's see here. Let's see if we can go another question before we get up out of here. Let's see. I'm an internist. Let's see here. All right. If you've been told you're pre-diabetic, have tingling in your upper lower extremity, one side. So I'm not sure necessarily if the concern is that the pre-diabetes could possibly causing that. Not necessarily. It's not necessary that the diabetes could be affected because, like I said, you can have a few different reasons why you have kind of numbness and tingling, especially if it's on one side or the other. But there's always concern, especially for my diabetics who are long-term diabetics, that neuropathy definitely can kind of set in. Typically we do this live. Usually we start at 9. Go for about an hour or so. Let's see. MP says it's because you sleep on that side. Would you get it after? It's so funny. It depends on how long, you're having numbness and tingling, right? Can you have some type of nerve impingement by, your neck sitting on that side? But it typically should wear off. It shouldn't be all day, right? It shouldn't be an all day affair of you having numbness and tingling on one side, if you're sleeping on your arm and everything else in that regard. We usually just do it Thursdays, but I think we are going to start doing it a little bit more often here on TikTok because y'all be asking some great questions. Let's see. Okay, I'm about to get up out of here. We appreciate everyone. Appreciate everyone for joining. Definitely follow. We had some great people on here. She is Beauty. It was a good one. Cardiology, NP. She used to do critical care medicine. I love that for her because critical care medicine. No, I'm an internist. I try to stay at the ICU as much as possible. It's just me. And if you missed this, I will be posting this episode on my YouTube page. Link is in said bio. And then if you like podcasts, I will post the audio version of this on my podcast, Lunch and Learn with Dr. Barry. Link is all in said bio, man. But y'all be blessed. Y'all have a great evening. I appreciate y'all for joining, and I'm gonna see y'all next time we go live. Bye.